We just have a couple of announcements before we get started. We wanted to make sure everyone stops and signs or makes a card so that we can give those out. And just an announcement that if you haven't signed up for Zazarak tonight, that we still have spots that you can fill. We also wanted to mention that we're going to finish this session a few minutes early so that we can all gather in the main room. So on your way out, please grab your box lunch as you head into that main space again. And I will give it to Chelsea.
Our first speaker today is Mark Nuszkowski. Oof, that's a mouthful, huh? So he has over 20 years of experience, and he's currently chief perfusionist at Children's National Hospital in Washington, D.C., and he's presenting Learning to Muff Again.
Hi, good morning. Thank you to the committee for the invitation to present on this hot topic. I'm grateful for the invitation and I look forward to sharing our insights and hopefully engaging in some audience participation at the end. Before I begin, I can provide the standard disclosure that I have no disclosures and the remarks are that of my own views. The technique of modified ultrafiltration, MUF, was introduced by Elliott at Great Ormond Street in 1991. It continues to be widely applied after weaning from cardiopulmonary bypass and before protamine administration at many centers undertaking pediatric cardiac surgery. The MUF debate, much of this controversy stems from the lack of standard definition or method for modified ultrafiltration, or MUF. In the initial report, MUF was performed in the arteriovenous fashion as the method was described. After separation from CPB, blood is withdrawn from the aortic cannula and passed through the hemofilter. Concentrated blood is returned to the right atrium. As fluid is removed from the patient, the filling pressures decrease. Blood from the cardiopulmonary bypass circuit is concentrated with the filter and infused to maintain intravascular volume. MUF thus provides capacity to remove excess water from the patient and salvage blood from the bypass circuit. MUF is continued until the hematocrit is 40% or no blood remains in the circuit. Now, we are aware of the multiple updates in bypass circuitry and the multiple configurations today and the potential placement of a hemoconcentrator. With arteriovenous ultrafiltration, A is showing the post-arterial filter to the venous reservoir. B is showing the hemoconcentrator from the arterial line to the venous line, a classical connection method for MUF. And C is the recirculation line to the venous reservoir or venous line. D is from the arterial line to the cardioplegia delivery line. For venous ultrafiltration, A is showing the hemoconcentrator placement of the venous line to the venous reservoir. B from the pump boot after the main pump to the venous reservoir. And C is from the vent line to the venous reservoir. This is a picture of the cardiopulmonary bypass circuit we used at Children's National in the early 2000s. Working alongside Richard Jonas, an antagonist of the benefit of ultrafiltration, his views have been debated well across the stage of this continued MUF debate. It is well known the use of cardiopulmonary bypass in pediatric cardiac surgery is associated with significant inflammation, fluid overload, and organ dysfunction, yielding in morbidity and mortality. For decades, various intraoperative ultrafiltration techniques, such as conventional ultrafiltration, CUF, modified ultrafiltration, MUF, zero balance ultrafiltration, Z-BUF, and a combination techniques, Z-BUF, CUF, MUF, have been used to mitigate these toxicities and promote improved postoperative outcomes. However, there's no consensus on the ultrafiltration technique or strategy that yields the most benefit for infants and children undergoing open heart surgery. Dr. Jonas raised an important question as to whether the risks inherent in performing MUF can be justified in the current era of low prime volume pediatric circuits, avoidance of hemodilution using bypass, and the efficient use of conventional ultrafiltration. There's conflicting evidence that MUF, cuff, Z-buff, cuff plus MUF culminate in reduced ventilation time and ICU stay. There's even less data about systemic inflammatory response utilizing these various techniques with today's smaller circuits. It has also been argued that it is important for us to recognize that conventional ultrafiltration and modified ultrafiltration are not competing, as they are not mutually exclusive techniques, but rather complementary techniques with potentially additive positive effects. As the technology and practice of CPB change with decreased hemodilution, introduction of smaller circuits, and the less use of hypothermia and circulatory arrest, the indications for ultrafiltration are likely to continue to change as well. The results from these trials shown in this slide, MUF reduces the amount of circulating inflammatory factors. There are some inconsistent trial results that can be explained by the heterogeneity in ultrafiltration, clinical staff preferences, institutional protocols. These studies date from 1998 to 2013. As we navigate through an ever-changing world, research is critical in helping us to understand and adopt new developments. It allows us to identify and capitalize on new trends and to anticipate and mitigate potential risks. Colleagues at Children's Hospital in Colorado, in their pediatric cohort, figure 3, the lowest hematocrit was significantly higher in the no MUF group versus the MUF group, 32.8 versus 31.1. And in their neonatal cohort, figure 4, the last CPB hematocrit was significantly higher in the no MUF group versus the MUF group, 40.9 to 36.8. Colleagues in 2018 reevaluated the importance of ultrafiltration at their centers overseas. The proportion of patients who received packed RBCs was significantly smaller in the MUF group in the overall cohort. And in the low weight cohort, the difference nearly reached statistical significance. On the other hand, the proportion of patients who received FFP was significantly smaller in the non-MUF group for the overall cohorts and the low weight group respectively. There's no difference between these groups in both cohorts regarding the proportion of patients who received platelets and cryo. In relation to the blood volume of these products for these patients who received in the overall cohort, the MUF group received significantly more PRBCs than the non-MUF group, while the low weight group cohort, the volume transfused platelets was also significantly greater in the MUF group. This is a picture of our current design back in January with the Livanova S5 pump configuration, the Spectrum Viper electronic data management system, and the Spectrum saturation module, along with the Terumo CDI 500, Hemocron Signature Elite, and the Radiometer 825 blood gas machine. When first supplied in London, the basis of their approach was to remove a greater volume of fluid that had been achieved with cuff while using MUF. Over time, the improvements in CPB and continuous ultrafiltration have resulted with significant increase in the efficacy of conventional ultrafiltration. Over the years, our team challenged ourselves to utilize all the residual volume in our circuits, hence the resistance from fellow team members. Our priming volume for our smallest patients is about 170 to 180 mLs, give or take the level in the reservoir. Our blood prime typically consists of 80 to 100 mLs of packed RBCs and 120 of fresh FFP. We wash with a cell saver all our packed cells for any patients 10 kilos or less and pre-bypass ultrafiltrate the crystalloid volume from the circuit before initiation. During bypass, we utilize continuous ultrafiltration throughout the case and begin to Z-buff when the lactate is greater than 3 micromoles per liter with either plasma A or normal saline to maintain the potassium level. We typically drain the volume in our hemoconcentrator and come off needing the volume in the reservoir and at times the volume in the venous line to fill the patient adequately to maintain right heart filling pressures. Once protamine is administered, we continue to flush the circuit forward if additional volume is requested or needed until there's no volume remaining, limiting the ability to muff in our current design. This question came up recently to the perfusion team, and surgeons had a meeting as one surgeon discussed the feasibility of including muff into our current practice. Since some surgeons and perfusionists were not sold on the technique, we came to the conclusion that each perfusionist would perform muff on 3 patients, simple tetralogy of flow, VSD repairs, and come back to the discussion with the results of the effectiveness. As we navigate through an ever-changing world, research is critical in helping us to understand and adapt to these new developments. It also allows us to identify and capitalize on new trends and anticipate and mitigate potential risks. 3 months later, our N of 1 configuration, I apologize, the picture was after I deprimed the circuit. Our last gas showing hematocrit on bypass was 32.6, using the LV vent pump with a short piece of 3/16 tubing to and from the table, connecting the primed hemoconcentrator, dropping some crystalloid volume to prime the muff circuit. We started to initiate muff for 10 minutes and 12 seconds. After there was no more volume in the circuit, we flushed the volume in the line and hemoconcentrator forward. The resultant hematocrit was 35.2. The patient was extubated in the OR, spent 4 days in the CICU, and 2 days in our step-down heart and kidney unit. With all the moving parts over the next few slides, over the last 6 months, it's been announced last week that the surgeon who requested we investigate the efficacy of this change to our practice of not using muff to using muff has accepted a position at a different institution. Biomed approached our team in October, another transition, that we would need to move forward rather quickly in purchasing new pumps or bypass machines as the current preventative maintenance agreement will run out at the end of the year. We trialed the Livanova Essence perfusion system in a non-clinical demo, took place outside a hall, November 27th to December 7th, creating a wet lab type setup for the team to utilize. The Spectrum Quantum system, we had a clinical demo that took place January 6th to the January 8th to the 26th. After too many unmentionable delays, our supply room was reconfigured to house 3 Spectrum Mr. Frosties and 2 Igloos. We were delivered the heater coolers and charging stations in early February of last month. The picture on the left is the Trumo Baby FX integral arterial filter, FX05, with the added medium flow heat exchanger. It added 22 cc's of volume with a flow of 3 liters. There's a smaller heat exchanger that only adds 11 mLs of volume and a flow liter of 1, or a flow max of 1, that we may be adding to our arsenal as the team gets more familiar with the system. The picture in the middle is our crystalloid cardioplegia setup for their HTK custodial. And on the right is a picture of our Del Nido 4-to-1, 1-to-4 cardioplegia circuit with the Spectrum heat exchangers. The configuration of the heat exchangers are ongoing as a team develops strategies on how best to incorporate the heat exchangers into our current circuits. And that was just the FX15 with the smaller 3-liter max heat exchanger. We were able to leave the configuration of the heat exchanger basically how it comes out of the bag without having to twist it. So we cut out the our line here had the heat exchanger, so it's basically right at the outlet of the pump and just enough to make that turn. Currently, we're just cutting the tubing, so it does have the ability to kink here, so that's pretty much our limitation in adding the heat exchangers to our circuits at that point. That everyone is making sure that they leave a little bit of extra room. We haven't made any pack changes. Livanova has a current cost. If we make any pack changes, they're going to increase our price $100 if there's just us taking stuff out of our pack. So we are not making a pack change until we actually have new pumps. Just because of a cost basis, it makes no sense that we cannot decrease our costs. Instead, they're just going to increase our costs because we want to take things out. So while many studies have shown decreased ventricular tachycardia, ICU, and hospital length of stay with MUF, many other studies have shown little or no benefit. Children's National is in the process of developing a prospective randomized control trial investigating inflammatory mediators, transfusion usage, and outcomes regarding comparing the use of MUF to a control group with a smaller, simpler size CPB circuit. The enrollment period will not take place until after new pumps have arrived, been ordered, configured, and the team has been adequately trained and IRB has been approved. While we have some time, we're still debating the N within our group and the statistician to rule out as many limitations as possible. This will be our second study undertaking and navigating inflammatory mediators while on bypass. The last time we looked at investigating the Terumo Baby FX or Baby RX-05 with the external arterial filter versus the Terumo FX-05 integrated arterial filter with patients less than 10 kilos undergoing cardiopulmonary bypass. The investigation did not find significant differences in cytokines. It is well known that the various mechanisms contributing to the levels of cytokines circulating in a patient's blood volume and the many manipulations through cardiac surgery have the ability to demonstrate anti-inflammatory interventions. We look forward to our investigation. So now I know we talked about this yesterday, but I just wanted, as we develop this study, I would like to do an audience poll, if possible. Real quick. So yesterday we did talk about, as everybody mentioned, so it's still pretty much an 80-20 to utilize ultrafiltration at your bypass at your institution. As you fill it in, it seems to still be 80-20 from back when I first remember hearing about MUF at a conference. And those, as we develop this study, we have been trying to figure out how best to configure the system. We use crystalloid cardioplegia. And we use crystalloid cardioplegia, and we have a 4-to-1 or 1-to-4 cardioplegia delivery system. So we're trying to decide if we're going to switch to Boston's technique of the way that they deliver Del Nido and just use a one-pump based system. So it would be important to learn other centers' ways of doing it. Do you utilize the cardioplegia circuit, a separate roller pump with the hemoconcentrator, or a totally different setup? And then the last slide is the one that's most important. This is where we're having a conversation on how to actually deliver modified ultrafiltration. Do you, since nobody has any volume left in their circuits, for modified ultrafiltration at your institution, how do you MUF? Do you MUF with the volume that anesthesia needs to give, as in additional FFP? Do you give cryo and platelets, or do you not give any of that?
Thank you, everyone. Mark, great job.
Sure, thank you.
So one announcement I forgot to mention was we're going to save all questions until the end. And our next presenter is Rachel Gambino. She graduated from SUNY in 2015, and she's been working at Duke ever since. She has years of experience in the hybrid adult pediatric perfusionist role as a full-time pediatric perfusionist right now. Her areas of interest are ECMO education, peds heart transplants, and peds ECMO transplant. Thank you, Rachel.
All right, thank you for that introduction, and thank you to the AMSTEC committee for inviting me here today. This is probably one of my favorite things that I've ever done as a pediatric perfusionist, so I'm very excited to share it with you guys. So this all started in 2019 when our adult cardiac surgeons did the first DCD heart transplant in the United States using the TransMedics OCS device. Since then, the adult team has performed over 100 DCD transplantations at our institution. Recently, last June, our adult surgeons published a randomized controlled trial comparing DCD versus DBD outcomes in adults and demonstrated comparable survival rates between the two groups at 12 months past transplantation. The next breakthrough that we had was we performed the first pediatric DCD heart transplant in the United States using, again, the OCS device. We relied heavily on collaboration with our adult heart transplant surgeons for this. And, this was very exciting, but this was an adolescent-sized patient. So, she was kind of more like a small adult. So what about our pediatric patients less than 40 kilos? We know as pediatric perfusionists, this population waits for a very long time on the waiting list and has a relatively high waitlist mortality. And they're also historically underserved in terms of innovations in VAD technology and also procurement technologies. So just some different procurement styles for these pediatric patients. So I went ahead and crossed out all of the TransMedics OCS methods because these hearts are too small for the current technology when they're less than 40 kilos. So, doing DCD procurements with no reanimation and just cold storage, there's like some case reports about that, but it's not really practical in a wider sense. So this leaves us with DBD with cold storage, which is what everyone's used to seeing, and then DCD with NRP reanimation and cold storage. So what is NRP? Normothermic regional perfusion for heart procurements involves the initiation of VA ECMO or cardiopulmonary bypass following exclusion of the head vessels, which obviously is very important, to reanimate and assess the heart in situ. So this is not brand new. This has been done in Europe and in many adult programs across the United States, but our pediatric surgeons thought that this could be a great option for our patients too small for the OCS device. So at this point, they decided that they wanted to pursue this. So our surgeons and our chief of perfusion, Desiree, as well as multiple of our adult heart transplant surgeons all got together. They reached out to other centers and they adapted current adult protocols down to sort of a pediatric level. So there's a couple different ways that you can do this that's described in the literature and at other centers. You can do this with full cardiopulmonary bypass. This was described in a paper out of NYU a few years ago. This, however, might be limited to in-house donors or transportation of the donor to your center, which is great for big urban areas, but maybe not for a more isolated center like ours. And then there's, maybe modified ECMO or mini bypass where you still have a cardiotomy reservoir for cardiac decompression if needed. But ultimately, what they decided on was that we were going to use a standard ECMO circuit. So the same exact circuit that we use at the bedside, which is a cardio help and quarter-inch tubing for our patients less than 20 kilos. So here's exactly how we do it. The procuring perfusionist, there's two of us go on all of these. We arrive about 2 hours prior to departure to start getting ready. So we have to verify that all the supplies are there. We have to build a new circuit. We have to test all the equipment, make sure it works. It takes 2 hours is pretty much the quickest we've ever been able to accomplish all of this. So this is most of our stuff. This first bag here contains the CardioHelp console with a primed ECMO circuit already attached to it and including a primed hemoconcentrator. It also includes a surgical tray with sterile clamps, heavy scissors, all of that required to initiate ECMO. And then this bag right here, I opened it up here for you so you can see inside. It's actually meant to hold a spare HLS set. So it's kind of hard to see, but it has this gray piece of foam and it just protects that HLS set from punctures and everything. So we also have a quarter-inch tubing pack and hemoconcentrator so that if something happened and our circuit were compromised, we could start all over again when we're out on the road. This is our NRP backpack, the little blue one. It has since been upgraded to a 40-liter hiking backpack because we have so much stuff. But that contains our pediatric cannulas, aortic needles, and all of the NRP specific things. We also have a dedicated NRP cooler where we bring 6 liters of Del Nido packed in ice. And then you can see our heater and blender there as well. Not pictured in that was our NRP drug bag. We have a pre-made order set. We worked with our pharmacy to make that happen. So we just call them as soon as we hear of a procurement and they prepare this for us. So at this point, this is pretty much how we feel. Unfortunately, a lot of times we're doing these at non-cardiac centers, so we really cannot pare this supply list down. We've tried, but we need to bring all this stuff. I forgot to mention, we also bring a tray full of sternal retractors for the surgeons. So it is a lot of stuff. So here we are on our way here. Some of you might recognize Scott in the bottom picture there. He is one of our fantastic NRP team members. So at this point, when we get there, one of the things that we've encountered, one of the challenges is identifying outlets and communicating any room limitations. So sometimes outlets are a really big problem. So we've toyed with the idea of bringing an extension cord, but again, our supply list is already so long that sometimes we just have to rearrange the room to make this happen. And then just recirculate the pump. And then our initial blood prime mixture is here. This is for NRPs. Our ECMO recipe at home is completely different. This is our NRP recipe, which is 1 unit RBCs, 50 mLs of albumin, bicarbonate heparin. And then we just displace the crystalloid and replace it with blood, similar to how everyone else would do it. And then we draw circuit gas. The potassium will most likely be elevated. I've done like 6 or 7 of these, and I've only ever had a potassium in range on the iStat on one of them. So they've all been greater than 9.5 in the unwashed red cells that we've been given, which is very unfortunate. And then at this point, we pre-buff the circuit. You guys are all peds perfusionists, you know how to do that. So I'm not going to go into too much detail. Just be careful if you're applying external suction on your effluent. We've had a few misadventures with that during priming. So just be really careful. Remember, it's different than doing it on a bypass circuit. We did find kind of a nice configuration of our stopcocks here. You can see so that the circuit will kind of pull in the volume it needs to maintain 0 pressure difference as the volume's coming off. So it usually takes a couple hundred cc's depending on your replacement fluid. So draw final circuit gas and give our remaining prime drugs. We wouldn't want to give these prime drugs before pre-buff because they could come off in the effluent. Global override on, sweep gas off, move circuit to the side and just cover it up so the family doesn't have to see this bloody mess. And then we leave the room with the surgeons. So before we leave, we make sure that 600 units per kilo of heparin has been given prior to leaving the room. And if that sounds like a lot for ECMO, you are correct. It is a lot. It's closer to a bypass dose. We have reasons for doing that, but we don't have a ton of time, so I can't get too much into it. But yes, it's a lot of heparin, relatively speaking. We leave the room with the surgeons, and the time limit from withdrawal to declaration is set by each individual center. It varies anywhere from 1 to 2 hours. So once death has been declared, there's a 5-minute standoff period, and then we re-enter the room with the surgeons. Once the standoff period is over, you can see what the surgeons are doing in the video. They're draping the patient and starting to gain access for sternotomy. Meanwhile, the perfusion team is administering any remaining prime drugs. The OPOs love to kick us out before we're done. It's a theme. So sometimes we have more to do to the circuit when we come back in, which is it's a little bit stressful. You saw us pass up lines there with the first assist, and you could see them cannulating here. Of note, the anesthesia team is also re-intubating the patient during this time. We do not, for our NRPs, place a PA vent or an LB vent. We start ventilating the lungs again to drop the afterload so the RV can, not be going against that high collapsed lungs. And then you can see here, they are getting the right atrial and ascending aortic cannulas placed, and then they are going to verbally confirm head vessel exclusion. So our surgeons will say head vessels are clamped, go on. And then our goal time from the end of standoff to going on NRP is about 6 to 8 minutes. Our surgeons kind of feel like any faster, you're getting a little bit frantic and you risk damaging the heart, and any slower, obviously you're battling ischemic time. So then it's just kind of normal ECMO stuff. So monitoring ECG, circuit pressures, patient pressures, drawing gases, checking electrolytes, transfusing if needed, all of these things. It's just all happening very fast. much faster than like bedside ECMO. You're trying to correct all these things within 30 minutes. So you're just kind of like rapid fire. And we're also communicating with TEE and surgeons regarding the patient's volume status. We know in these tiny kids how sensitive they are to volume, even in a very, very good heart that didn't just undergo this long warm ischemic time. And then you saw at the beginning of this, our surgeons were placing the aortic root cannula for patient MAP monitoring. So we can't use a radial A-line because we're going to clamp off the head vessels. The femoral A-line is okay in theory, but if they're doing an abdominal procurement, which they were in this case, the abdominal surgeons are a little heavy-handed and they kind of sometimes compress that A-line. So I usually pretty please ask the surgeons for an aortic monitor early in the NRP run. So after 30 to 60 minutes reanimation time, we begin our clamp trial with about 10 to 15 minutes of TEE observation and just direct observation. So the surgeon's looking at the heart and the hemodynamics. This is actually a very, very busy time for the perfusion team. We're doing all these things kind of at the same time. We're flowing through the bridge, keeping up with volume and calcium administration, which usually the volume administration is not that bad. But if the abdominal team is in there, I hate to keep picking on them, but they're a little bit messy. So we sometimes do have to give more volume if there's an abdominal procurement at the same time. We also have to maintain ECMO cannula patency in case the surgeons are like, oh, let's go on and give them some more time. They've yet to do that to me, but I want to be ready in case they ever decide to do that. And then they also, once they decide they're going to take this heart, they are going to, at the field, the surgeons will withdraw some blood so they can mix their Del Nido in a basin up there. So they'll tell us and we'll simultaneously have to give the patient volume. So it's a lot of communication with our surgeons. I'm very fortunate that ours are very easy to talk to and work with. So once we are done with NRP, it begins, the surgeons are going to apply the cross clamp and give Del Nido cardioplegia. They use 60 cc syringes for our smaller patients up to maybe 15 to 20 kilos or something like that. And then at the same time, the perfusion team is beginning our cleanup so that we're not delayed getting out of there. And then assisting the surgeons if they need help with a Sherpa pack or anything like that. So our program by the numbers, we've done 10 of these NRP procurements in pediatrics. They've all been less than 20 kilo patients. We had 7 successful recoveries that were transplanted into our recipients. We had 2 dry runs where the donor did not pass in the allotted time. And we had 1 unsuccessful reanimation due to severe LV dysfunction and distension of really unknown etiology. This was early on in our NRP time. So this was kind of a demoralizing a little bit, but we kept going, and that's the only time that's happened. So of note, our longest duration from extubation to NRP initiation was a little over 2 hours of warm ischemic time. And that heart did very, very well. I happened to finish the pump run when I got back, and I was very nervous when the cross clamp came off, but everything was fine. The heart came right back. So I've got about a minute and a half left. So just really quick, a few lessons learned and challenges that we've encountered so far. Like I said, the hyperkalemia in the donor blood, that has been a huge problem, especially because oftentimes there's a delay in getting the blood. That's the other thing. So the blood will get there and everyone's like, all right, are you guys ready to leave the room? And it's like, whoa, whoa, whoa. Like I need at least 20 minutes to get this circuit ready. And nobody really seems to understand that except us and our surgeons. So that's really hard. And then the A-line site, I already mentioned this, direct aortic is the best way we've found for if they're also doing abdominal procurements. The abdominal team can be a little messy, so we've got to be ready with our volume if they're going to be in there. If the abdominal team is not in there, we usually do these with just the 1 unit of RBCs in the prime, and that's all we need to vent or not to vent. Our surgeons feel very strongly that if this heart cannot hold its own without an LV vent, then it's probably not going to be strong enough to withstand another ischemic period. It is probably not good enough to put into our patient. So we used to bring LV vents and talk about putting them in. We have never actually done that. We did that once in the one heart with all the LV distension, and our surgeons decided they're not going to do that again. And then acceptable time limit from withdrawal to NRP initiation. We have decided that once we're there, we've got the circuit set up. We're just going to do that. You might as well try, because you can always assess the heart once you get on. And we proved with our 2 hours of warm ischemia that it actually can be fine. So we're like, if you can assess it in situ like we can with this method, then it's worth trying. I don't have time for this. I don't want to get us behind. So lastly, just some future directions and program goals with, I'm already just hit my time, but we hope to continue to learn and improve internally as a group and share our experience with other teams, which is why I'm so happy to be here, because we can reach more children outside of Duke's recipients. If you guys want to bring this home and maybe get this going with your surgeons, that would be awesome. And then the last two are kind of surgeon driven, but contribute outcomes data to prove safety and efficacy of DCD hearts in children less than 40 kilos, similar to what our adult surgeons did. And lastly, increase experience with predictive models for pediatric donor criteria to reduce the likelihood of dry runs. So there is a set of criteria for these DCD patients that's going to say how likely they are to pass within the allotted time. Unfortunately, these predictive scores come from adult data, and in children, it is completely different and they're not very useful. So hopefully with more experience, we can help contribute to that. Thank you so much. I don't know if we're going to get to Q&A in this session, so feel free to write down my email if you guys have any questions or want more information. Let me know. Thanks.
Thank you, Rachel. Sorry about the time constraints today, but great talk. So I'm going to introduce Phoebe. She's coming to us all the way from the Dominican Republic, where she is Chief Perfusionist and Director of Extracorporeal Circulation Master's Program and Director of the Latin American Board of Cardiovascular Perfusion. She's going to present sickle cell patient experiences.
All right. Thank you very much for the introduction and for the space to share with you our experience back down there in the Dominican Republic in terms of sickle cell anemia. So this is, I plan to get through this agenda: history, physiology, incidents, and our protocol. So a little bit of history. Linus Pauling and his colleagues described series of elegant experiments that confirm intrinsic difference in the hemoglobin of patients with sickle cell based in patterns of electrophoresis mobility. Basically, it was because it's charged. Hemoglobin of sickle cell patients were charged positively, and our hemoglobin, or hemoglobin A, is charged negatively. So this discovery led to the designation of sickle cell anemia as a molecular disease because it was categorized as a single dysfunction protein. So this is good to know us as perfusionists that the normal types of hemoglobins will be hemoglobin A, hemoglobin A2, which is less than 5%, fetal hemoglobin, and also we would be in contact with HbA1c, which is the the glucose hemoglobin. So in terms of physiology, basically what happens here, it's a single base pair mutation. As we can see in the screen, it's a mutation, a flip over of the adenine and the thiamine, and we will see it in the sickle cell. What is going to happen? That the protein, the normal protein, should be glutamic acid, and now it's going to be valine, okay? And the different, and what is important is that one is hydrophobic and the other one is hydrophilic, okay? So this is very interesting because this pathology is basically in the beta change of the hemoglobin, and there are 5 types of sickle cell that we can, or 4 types of configuration. The normal hemoglobin, as we can see here, there are the 2 types of the beta change, and it happens in the 11th chromosome, specifically in the 6th position. And so for a regular hemoglobin in the 2 beta chains, you get one from your parent, from your mom, and the other one from your dad. So you will see the glutamic acid adequate position. Then we have the heterozygous, which it's the most common, which you can see hemoglobin S and A. In one chain, you will see the current glutamic acid, but then you will see the valine. This is the problematic of big cases that we could get, which is the homozygous type of sickle cell, which you don't get hemoglobin A, you get hemoglobin S and S, 2 valines. Then there is another type of sickle cell, which is called double heterozygous, where you won't get hemoglobin A, but you will get hemoglobin S and C. I've seen a couple of those, and you will see a valine and then a lysine, a protein called lysine. And then there's the other one called beta thalassemia. That is less frequent. So between these types, the most common will be the HBSS, which is the sickle cell. In terms of incidence, you can see that it affects people from Africa, Indian, and Arab ancestry. In the United States, so far, there are 90 to 100,000 patients living actually with sickle cell anemia. As you can see from red and getting yellowish and orange, patients most likely will be where these ancestors are located, but we have to take in account the huge migration seen worldwide right now. For example, one of our students is from Chile, and he went back to Chile, and he called me and he said, listen, they're telling me that I had to give a talk on sickle cell because they're starting to see a lot of sickle cells here because of the migration from Haiti that has been seen in Chile. So from the genetic stand of view, how can a person or a patient get sickle cell anemia? So if two parents get married and have a children and they have trait, they will get one sickle cell patient, two traits, and one with nothing pathological. If another one pathological or a trait gets and has babies with a non-sickle cell trait or patient, it will only get out of 4 2 trait sickle cell patients. From the physiology, so sickle cell is a multi-organ, multi-systemic disorder with both acute and chronic complications. It is not presented when the kid is born because it starts to develop when the fetal hemoglobin changes to hemoglobin A between the 5th and the 6th month. So we can see here the normal hemoglobin, the adult hemoglobin, 2 chains of beta and A and the alpha, and in the fetal, 2 chains of alpha and then 2 gamma that will change when the patient grows up about the 5th month. So as we all know, hemoglobin is quaternary structure, and the beta change will sickle and will, because of the hydrophobic formation that would happen. How does it happen? Basically, what happens, or the shrinking of the cell will happen by something called a channel that is called the Gardner's channel. So when hypoxia is seen, it will induce and open the calcium-activated potassium channel, and it will cause cell dehydration. So the sickling of the erythrocyte results from increasing of the intracellular hemoglobin S, and that is why it will adopt this form. Opening of the Gardner's channel, it is an important mechanism of sickle cell dehydration which is temperature dependent and with greater potassium efflux at lower temperatures. Shrinkage of sickle erythrocytes may also result from activation of potassium and chlorine co-transport during acidotic conditions. So activation of these pathways can be blocked by increasing the abnormally low levels of intracellular magnesium. So it's a good key to know that magnesium, we could add it to the pump for these patients, as I'm going to say after this. So in summary of the pathophysiology, we will see the mutation, as I said before. So the Gardner's channel will open, the red blood cell will sickle and polymerize, and then what is going to happen, the free hemoglobin will attach to the nitric oxide, and it will cause vaso-occlusive crisis for these patients. It's important to know that the glycocalyx, it's a structure that it lies in the endothelium, and it's negatively charged. As I said before, or about platelets and regular red blood cells, they are charged negative as well. But the sickle cell, it's going to be charged positive, so it's going to disrupt this glycocalyx, and as you can see, it's going to be exposed the nitric oxide where it's developed in the endothelium, also adhesion molecules, and of course, edema and permeability. Some clinical manifestations, like the most likely that we need to know, are strokes and pain episodes. You can see them here in the screen, but from the point of view of cardiopulmonary bypass, we have to avoid hypothermia, hypoxia, and acidosis as well. So far, the treatment for these patients are N-acetylcysteine, also magnesium, antibiotics, and hydroxyurea. Why this hydroxyurea? It's a medication given in cancer, and what it will happen, it will get the hemoglobin S out of the circulation and promote hemoglobin F. So the patient will live with fetal hemoglobin being an adult. And this happened in December last year. FDA approved 2 gene therapies for children over 12-year-old. And the gene therapy is approved to change the hemoglobin in the bone marrow for displacing forever hemoglobin S, but they have only come to be possible to be hemoglobin A2 and I forgot the other one, hemoglobin A2, and hemoglobin F. So that's going to be like the treatment. Science has not been able to create hemoglobin A1, which is the normal one. So A2 and fetal. So back down in the Caribbean where we are located in the middle of the Caribbean next to Haiti. All right. And so our protocol in our institution is that we have to screen for every patient for sickle cell every day. So this is our normal chart. We will see, this is a word in sickle cell in Spanish, falsemia. So we will see if it's positive or negative. Our incidence is that every other month, we will see an trait or hemoglobin SA, 6 or 8 per year. 2 or 3 times per year, we will see a sickle cell patient, hemoglobin SS. So first of all, we will identify the sickle cell anemia. We will see if it's homozygous or heterozygous. We would determine if we're going to do a complete or a half protocol. This, we came up with this half protocol because we have seen or talked, like when you don't get too much exposed to this type of patients, you will do exsanguineo complete to all of the patients. We read some papers that when the patients are heterozygous, they won't do nothing to the pump or to this patient. So we came up to treat them differently. I'm going to explain it. In both situations, we bring the hemoglobin down S to less than 15%. We make calculations for prime, order products, we prime the pump and balance it. We do the exsanguineo with the prime replacement. The heater cooler, we place it at 36 degrees. And the cardioplegia, it depends on our protocol, if we're going to give half or complete protocol. So we do have to read the electrophoresis for every of these patients. And for example, here we will see that hemoglobin S is 40. All of the sickle cell traits, hemoglobin SA, they always bring 39%, between 38 or 39% of hemoglobin S. So we bring it down, or our target is to bring it down to less than 15. This is the patient that we saw, she was a double heterozygous. She was an adult, 37-year-old. And here you can see in the electrophoresis that we don't have hemoglobin A, it's hemoglobin S and C. So we had to bring down specifically the hemoglobin S to less than 15. So what do we call our complete protocol? This will be a sickle cell patient, hemoglobin SS. So we would do the exsanguineo transfusion. We could send all of the blood to the blood bank for autologous plasma and platelet conservation use. We don't do that. I heard it from someone from Costa Rica that they do it, and they basically give it back for platelet-rich plasma at the end of the surgery. So we discard that blood. And our cardioplegia, we warm at 37, or we give it warm until the heart is arrested. Then we stop the cardioplegia. We switch the heater cooler to cold. The surgeon will open the atrium and he will aspirate the cold cardioplegia to the wall. Our half protocol, and we won't cool those patients, of course. Our half protocol, we will again bring the hemoglobin to 15 less. We will keep the patient kind of drift at 35 degrees, and our cardioplegia will be normally cold, okay? The reason why we do give the cardioplegia cold for this trait patients is that when we go on bypass with hemoglobin SA, which is the trait patients, and hemoglobin S is less than 15%, hemodilution is going to bring it further down. And as I said before, numerous papers say don't treat the traits. So we do treat the traits, we hemodilute them, bring it down, but we treat the heart as a regular patient. All of our hemoglobin SA, we are done this way regarding myocardial protection. So this is one patient we had. This is the electrophoresis pre, as you can see here, where the heart is. It was hemoglobin S 39%. This is an HbAs trait. And we wanted to bring it down. And this is the electrophoresis from the next day. And the hemoglobin A is 16%. And the hemoglobin A went up, of course. So in conclusion, sickle cell anemia and thalassemia are autosomal recessive inherited disorders. You get it from your mom and from your dad, as they don't present the illness, but they are carriers and they transmit it when they get children. There are 4 forms that can be present: homozygous, SS, heterozygous, AS, and double heterozygous, SC, as you saw before, and beta thalassemia. Most likely is present in Africa, India, and migration, so perfusionists must be aware. Approximately 5% of the whole world population carries potential pathological gene. Polymerization occurs by hypoxia exposure, acidosis due to cell dehydration. In cardiopulmonary bypass, high venous saturation should be kept above 85%, no cooling, myocardial protection. In terms of that, special considerations should be kept, especially washing out coronary circulation from HBS. No acidosis and no saver. So this is finally the last slide. This is us doing the exsanguinal transfusion. So we do it in pediatrics by syringes, 50 cc syringes, and the pump is blood balanced brine with FFP. We have made our calculations before how much we're going to extract, if it's a total or a sickle cell SS or a trait SA. So this one was the patient that I showed before the electrophoresis. Thank you very much.
Thank you. That was a great presentation. Our last presenter is Matt Medlin. He comes to us as an associate chief from Walson Children's in Jacksonville, Florida. Thank you, Matt.
I promise I won't keep you long. Lunch is right around the corner. I'll go through this quickly for you. All right, I'm gonna talk about a case, kind of our technique that we do at Wolfson's, neonatal aortic arch reconstruction using head and heart perfusion at 34 degrees. I have no financial interest or relationships to disclose. What is the diagnosis? Anybody? Come on. You get a bag of coffee. Long segment hypoplasia of the transverse arch and a PDA. A couple of the objectives: we're going to identify the indications for neonatal aortic arch reconstruction, pre-op management, our surgical approach with mild hypothermia and head and heart perfusion, and explain the conduct of perfusion for neonatal arch reconstruction. This was a great paper, normothermic versus hypothermic Norwood procedure. They looked at the Norwood procedure normothermic greater than 34 degrees, and then they looked at it also at less than 34 degrees, both with selective cerebral. And you can see the numbers here. So greater than 34 degrees with the Norwood selective cerebral, bypass of 90, cross clamp 45, and selective cerebral at 25. Less than 34 degrees, you see the difference in the times. So from the article, shorter bypass time, shorter cross clamp time, shorter selective cerebral time, and lower lactate levels. So some indications for surgery, a gradient across the coarc greater than 20 millimeters of mercury. If the diameter of the transverse arch is less than the patient's body weight at repair plus 1 millimeter, and then a Z-score of less than 2. So this is the case report here. So 6-day-old term neonate prenatally diagnosed by the pediatric cardiology with concern of hypoplastic aortic arch. Found after birth to have several or severely hypoplastic aortic isthmus, a large PDA, and dysplastic and prolapsing mitral valve and PFO. The neonate was started on Prostin in the NICU. They were transferred to the CVICU on Prostin. They were tolerating feeds. They had a UVC and a UAC in place. The height was 53.5, 4 kilos, a BSA of 0.24. So arch hypoplasia, a PDA, and bi-V heart failure. So we can see from the CTA measurements, if you look at the proximal, we're at a Z-score of negative 2.37. The distal is at negative 2.55. And then at the isthmus, negative 3.91. And you can see how big the PDA is at 7.3 millimeters. And then how long the long segment is. And then you can see it right here. And you can see how large the PDA is. So this is the technique that we use at Wolfson Children's. We use a hemi-PA graft material. So we cannulate the bottom of the innominate artery. I use an 8 French Biomedicus arterial. If there's no intracardiac work, I used a single, it's a right angle metal, a 16, normothermia or mild cooling, 34 to 35. Control the ductus, ductal ligation and division. We controlled the head vessels, and we put a clamp on the distal aortic arch. So you can see where the clamp is on the distal aortic arch here. So this is when we're going to go head and heart. So for our distal arch reconstruction, selective head and heart, so we flow 80 to 100 mLs per kilo per minute for head and heart perfusion. We also measure bilateral nears. We have flank nears on. Does a lot of people measure flank nears? Yeah. And then for the proximal part, when we bring it around here, we're going to cross clamp, pleage. We use Del Nido. We're going to get 30 per kilo. And at that time, we advance the cannula and snare that down. And we're going just selective cerebral. And we flow 40 to 60 mLs per kilo. And we target a radial pressure of 35 to 40. The proximal arch gets filleted open, and the remainder of the proximal arch is reconstructed. We de-air the arch, we release the head vessels, de-air the heart, then release the cross clamp. This ends the period of selective cerebral. The heart, the head, and the body will be perfused at that time. Check for bleeding and wean down off bypass. I've got to get something off my chest. Circ arrest is not always the best. I know I'm going to get a lot from this. So how many people have weaned a 3 to 4 kilo neonate with a centrifugal pump on bypass? So that's what we use. They were using it when I got there. So we used the Biomedicus, the BP50. We still use the Quest. We recover all the blood during rewarm. So we have a system one, and we've got the vents mounted really close. Hemoconcentrator, the Quest, CardioHelp, CDI 550. We use the iStat. We have the Prime Plus, the Epoch. We do Syntegs, baseline, rewarm, and post bypass, and then we use Epic for charting. This is the Prime albumin. We do 1 unit of packed cells. Anybody less than 4 months is going to get irradiated blood. And then the blood bank also sends it up to us washed. I do still P-buff it because the sodium they wash in the blood bank with normal saline. We do 100 of FFP, and then we give the remainder on rewarm. Less than 5 kilos, we dose 1,000 units of heparin, and then greater than 5 kilos, we do 200 per kilo. Bicarb, mannitol, Lasix, Solumedrol only on the neonates, and then 100 of calcium. Some flow is better than no flow. This is just a recap. Arterial, single venous. We did use a LA vent, a 10 French, and then we use an angiocath to deliver cardioplegia. Cooled 34 degrees, gave Del Nido. Just to recap, head and heart perfusion during distal repair. That's 80 to 100. And then for our selective cerebral during proximal is 40 to 60. We always have 2 A lines. We have an upper and a lower. We have a right radial, and then the kid came in with the UAC, bilateral nears, flank nears. So as far as bypass flows, I flowed 150 to 200 mLs per kilo, which is a 2.4 to a 3.0 index. Modified pH stat ventilation with normoxia. You can see the ACT ranges here. So baseline on bypass, and then post-pertamine. The crit in the OR was 41, the lowest on bypass 37, and then post-pertamine 42. The lactate was one thing I really wanted to focus on. Baseline was 1.9, so the neonate came to us with a little bump in the baseline lactate. Highest on bypass was 4, and then post-pertamine it was down to 2.5. And then you can see the nears here during head and heart. There's the nears there, right, the left and the right, and then during selective. And then of course, we're pretty much clamped out to the distal extremity. So you can see during the head and heart, and then during the, this is for the flanks, the flank nears, and then during selective. So you can see my bypass times. Bypass was 82 minutes. Cross clamp was 72, head and heart 23, and then for just head only 17. So as far as the timeline goes here, so case start to case finish, 200 minutes in the OR to out of the OR was 320. Post bypass TEE, this was a status post, the arch repair, PFO left to right, not well seen. No significant valve dysfunction. Unable to visualize the aortic arch by TE, but there is reassuring flow pattern in the descending. Post-op chest closure on day 2, extubated day 3, and then discharged home day 10. Just some quick final take-home notes. There are many ways to do an arch reconstruction, that other surgeons use that are met with good results. We've noticed shorter bypass, cross clamp, selective cerebral, less bleeding, and early chest closure and extubation. References, that's me with that centrifugal pump. And then acknowledgements. Thank you very much.
Thank you, Matt. Thank you, everyone. We've run a little over, so if everyone wants to get up, go grab lunch and get into the other room, for that'd be great. Thank you.